First of all, just want to wish everybody a happy birthday, happy anniversary, and just thank you for all that you do for all the patients that are affected by this disease. So it's really incredible to have Dr. Drapkin and Dr. Gershenson, who are great friends and experts, and to be in the company of these two great men and to follow them. So I'm gonna do my best. I just kind of wanted to chat a little bit about what, as Dr. Gershenson talked about, this is a lived history for us, and thinking about what advances have happened over the past 30 years. I finished my fellowship in 1990, and we had the discovery of paclitaxel, we had this discovery of the BRCA genes. The late 1990s were mostly about a number of different types of cytotoxic agents. Early 2000s were about intraperitoneal chemotherapy. More in the late 2000s or early over the 2000s, we studied anti-angiogenics and understood better about the tubal origin of high-grade serous carcinoma. And in the last decade, it's really been about neoadjuvant chemotherapy and PARP inhibitors. And each of these areas have actually inched us forward in resulting in better outcomes for patients with high-grade serous carcinoma. So let me just move this slide. And I think what's been an incredible study is SOLO-1 that looks at PARP inhibitors in newly diagnosed ovarian cancer patients who have a BRCA mutation. And it's really been a game changer. And Dr. Weston is going to talk about this, so I'm not going to steal her thunder. But I think this has been one of the pivotal things that we've seen over the past few years. And as Dr. Gershenson and Dr. Drapkin both talked, I had a chance to participate in the Institute of Medicine program that looked at the research on ovarian cancer in the around 2015, 2016. And we couldn't emphasize enough how ovarian cancer sort of represents a spectrum of diseases. And you've seen some facsimile of these slides presented by the prior two speakers. So I'm mostly going to focus on high-grade serous cancer and maybe high-grade endometrioid cancer. You already heard from the guru of rare ovarian cancers, Dr. Gershenson, who's done a phenomenal amount of work in particularly these rarer tumors, and particularly low-grade serous carcinoma. But most of what I'm going to talk about really is going to be focusing on these high-grade serous and endometrioid tumors. So today I'm going to talk a little bit about some targeted agents, so focus on some PARP inhibitor combinations, antibody drug conjugates, and immunotherapy. And I think, all of the advances that we've made, which have been incredible over the past couple of decades, is about our ability to sort of understand the molecular and other events that are involved in a cell turning from normal to cancer. And this diagram here is just a sort of a summary of the major categories of things that happen to cells that involve what happens inside the cell, what happens when the cell is interfacing with the tumor microenvironment, like the immune system, or like with the vasculature. So it's amazing all the different things that have to happen for a cell to turn into a cancer and then metastasize. And we are understanding those processes better in ovarian cancer than we ever have. And I think that's leading us to many of the explosion of new therapeutic options for patients with ovarian cancer. So let's talk a little bit about targeted agents. And, one of the things that cells are really good at are sort of, cancer cells are good at are sort of repairing DNA damage. And that's why the process by which DNA repair actually happens is very complex. And you're seeing, this is like looking inside of an engineer's diagram of how these different things happen to cells. But you can see I have sort of outlined in a box in blue boxes key areas or key processes that are involved in the repair of DNA damage, and how drugs can be developed to target these areas and inhibit the ability of the cell to repair its DNA and consequently lead to cell death. And you can see one of those drugs is the PARP inhibitor. You're going to hear a lot about that from both me as well as Dr. Weston as she talks about maintenance therapies. But others that are on this include the ATR-ATM genes, the WEE1 genes, and the CDK4/6 and cyclin D genes. And you can see I have outlined here a number of different drugs that are being investigated. And I'm going to talk about a few of them, just give you a few examples of this. So WEE1 is a gene that actually, when cells are or have DNA damage, WEE1 is a gene that will help the cell stop before it goes into and repair that damage before it goes into trying to divide. And so there's a drug called Adavosertib that has been investigated in patients with platinum-resistant ovarian cancer in combination with chemotherapy. And you saw an overall response rate when the drug was given in combination with carboplatin of about 67%, with a PFS of about 10 months. So that's a pretty remarkable overall response rate in patients with platinum-resistant ovarian cancer. And it seemed to be linked to patients that had a gene that was amplified, a gene called CCNE, which was amplified. So it may be a biomarker of who may be able to respond best to this combination. And you can see I've listed here a number of different trials that are have been published and looked at either as in randomized studies with a variety of different chemotherapies and a variety of different types of patient populations, both platinum sensitive and platinum resistant. There for your information. These are some other genes that are in that box that are being inhibited. Clinical trials that are looking at this there's a GOG Foundation trial looking at an ATR inhibitor in combination with gemcitabine. That one's in development, a phase 3 trial. The early phase, randomized phase 2 trial results showed some promising improvement in outcomes. There's drugs that are looking at a HER2 new inhibitor, neratinib, in combination with a CDK4/5 inhibitor, palbociclib. And then you heard Dr. Gershenson talk about MEK inhibitors, and these are being looked at in combination with PARP inhibitors. And there's another with AKT PI3K inhibitor, Adavosertib, that's being looked at in combination with chemotherapy for neoadjuvant treatment of patients. So there's a lot of exciting things that are happening across both the newly diagnosed patients, so even those patients that are have platinum-resistant ovarian cancer. A very interesting one is one looking at AVB500, which is an AXL signal inhibitor. So I want to talk a little bit about PARP inhibitor combinations, and some of this builds off of the previous information that I've talked about, where you can see how PARP is important for DNA repair mechanisms, and how it can be utilized alone and in combination with other treatments to be able to affect responses. So again, I just wanted to say that we talk about these tumors as though they're like high-grade serous tumors, as though it's one cancer. But when you take high-grade serous cancers and looked at the TCGA data, which was the National Cancer Institute's efforts to do sequencing of a number of different high-grade serous carcinomas, you can see that in and of itself, that represents about 20 different diseases. So it's very interesting to see how even within one category, and I think Dr. Gershenson showed that in some of his low-grade serous carcinomas and some of the endometrioid carcinomas, there are subsets of various different molecular features for these cancers. And in high-grade serous carcinoma, we know about 50% of these may have homologous recombination defects, either related to BRCA or to other processes, which make them generally more sensitive to PARP inhibitors. But there are a group of patients that are, we call homologous recombination proficient, or even those that are more sensitive to PARP inhibitors that become resistant to PARP inhibitors. So there's a number of different ways by which patients become resistant to PARP inhibitors. Some of it is really direct, and that is where they originally have lost the functionality of the BRCA gene to some degree. They have reversion, and the BRCA gene becomes active and able to repair the DNA. Some of it is indirect, where there are other mechanisms that make the cells become more resistant to PARP inhibitors. Some have to deal with the way that DNA repairs itself, either through what's called fork stability or the cell cycle control. And some, we just don't know. There's many different ways by which it could happen. But what I wanted to kind of look at was just a few combinations of PARP inhibitors that are being investigated, and share with you some of those clinical trials. So we know anti-angiogenic agents actually make tumors hypoxic, and that hypoxia actually decreases the BRCA, the genes that are responsible for homologous repair of DNA. And so when you actually, that will make a cell actually even more sensitive to a PARP inhibitor, and you get a lot of synergy between the PARP inhibitor and anti-angiogenic agent. And here's just a number of different trials. The agents really aren't that important necessarily, but they involve PARP inhibitors plus anti-angiogenic agents. The PARP inhibitors are olaparib and niraparib. The anti-angiogenic agents are bevacizumab, cediranib, and there's a number of different trials that have investigated these. So there's a big phase 3 trial that was conducted by the GOG that looked at standard chemotherapy in patients with platinum-sensitive ovarian cancer versus a combination of olaparib and cediranib. Thinking that maybe there's a situation in which we wouldn't necessarily have to use chemotherapy in the second line. We can use something like a PARP inhibitor and anti-angiogenic. There really wasn't any major benefit of olaparib and cediranib, but it seemed to perform similar to chemotherapy, but it wasn't really designed to be a non-inferiority study. And you can see there are some other situations where you see when you put a PARP inhibitor together with an anti-angiogenic, like the Avanova trial, that it seemed to work better than when you just gave the PARP inhibitor alone. And so another pathway, and you heard Dr. Gershenson talk about this somewhat, is the PI3 kinase pathway. It sort of interferes with a number of different pathways that actually will suppress the BRCA expression and loss of homologous recombination. So it makes it susceptible to a PARP inhibitor. So here's just an example of a clinical trial that looked at PARP inhibitor olaparib together with the PI3 kinase inhibitor alpelisib. These names are kind of challenging sometimes. Alpelisib, that's it, better. And as majority of these patients had BRCA wild type, they were not BRCA mutations, and they had platinum-resistant ovarian cancer. And so in this trial, they showed the maximum tolerated doses demonstrated there. And they had a partial response rate of about 36% and stable disease in about 50%. And you can see this is a plot that shows how well patients responded. And you can see a significant number of people that had over a 25% response rate in this, and which was really amazing. And there are other trials that are looking at this type of PARP inhibitor, PI3 kinase inhibitor combination in patients with who are either platinum-resistant ovarian cancer or who have been on a prior PARP, and looking at this combination to see if we can increase improve the outcomes when we use them in combination. So you heard me talk about ATR inhibitors when I talked about targeted agents. And so again, ATR is involved in sort of stabilizing the DNA as it's repairing. And if you inhibit that and use it together in combination with a PARP inhibitor, you mess up the ability of the DNA to repair itself, and it can actually result in cell death. And here's a couple of trials that have been published just recently, one a basket trial and one the Capri trial. And you can see again that the overall clinical benefit rate was about 62%, and particularly high in patients that have PARP-resistant high-grade serous carcinoma. And then in the Capri trial, this was mainly platinum-resistant ovarian cancer, had stable disease in 9 of 12 patients, with the best response being in patients that had BRCA mutations. And you can see that change in the disease status from demonstrated on the lower right hand. So immunotherapy is obviously, we'll talk a little bit more about that in just a few minutes, but it's also a mechanism by which we can have an enhanced response when used in combination with PARP inhibitors. So PARP inhibitors have obviously direct cytotoxicity effect on cells, but they also work in an indirect way that seems to be mediated by changes in the PD-1, PD-L1 stimulus to tumor cells, or to, T cells, and mediated by other things that happen in the tumor microenvironment. So this dual activity of damaging the DNA and activating the immune system seems to have some synergistic effect. And here's just a number of different clinical trials that have looked at various different combinations. The Mediola trial looked at the olaparib, which is the PARP inhibitor, and durvalumab, which is actually a checkpoint inhibitor in patients with platinum-sensitive ovarian cancer. And you can see that pretty significant response rates of 72 to 87%, particularly in BRCA mutant patients when you use dual therapy, and when combined with the bevacizumab, had a really good result even in the BRCA wild type patients. And I'll list here a number of different other trials that are looking at a variety of different PARP and immunotherapy combinations that have been reported or are ongoing. Well, let's talk about a little bit about antibody drug. So we talked about targeted therapies, we talked about PARP combinations. Let's talk about antibody drug conjugates. This is an exciting area. And antibody drug conjugates are really just is an antibody that's designed to target a specific receptor on a cancer cell. It has a link to it, and that helps bind this what's called a payload, which is generally some sort of compound that's cytotoxic to the cell. And probably the prototype that we've been talking a lot about lately is mirvetuximab soravtansine. We call it MIRV for short. And it targets the folate receptor alpha, which is highly expressed on ovarian cancer. And it delivers this DM4, which is a tubulin targeting type of agent, much like Taxol. So there was an initial trial that actually looked at it in platinum-resistant ovarian cancer, but didn't really meet its objectives because they used a different way to kind of measure folate receptors on ovarian cancer cells. But when they looked at a subset of patients who, when they used a different methodology to measure folate, really get those ones with very high levels of folate receptor positivity, they actually saw some signal of activity. So we just recently had the SORAYA trial that was presented last week at SGO that showed it was a phase 2 trial of mirvetuximab in really the high folate receptor positive platinum-resistant ovarian cancer patients. And this trial had an overall response rate of 32%, which actually compares to generally about somewhere in the neighborhood around 15% for patients treated with standard chemotherapies like Doxil, Adavosertib, Taxol, And amazingly, in this study, there were 5 patients that had complete response rates. And so it's been really very exciting to see development of this class of drugs for a specific population of patients. There is a phase 3 trial that's ongoing, looking at it in patients with platinum-resistant ovarian cancer. And there are actually just a number of other trials that are in development. And I think this is going to be an agent that you'll see out on the market soon to be able to treat a really subset of patients, which is not inconsequential, 40 to 50% of people that have these folate receptor expression type tumors. So this is a big area that's being developed, and I show you here the names of a number of different agents that are being looked at and what they're targeting. We're, not only folate receptor alpha, but there's NaPi2b is another one, mesothelin is another, tissue factors. Tisotumab vedotin is actually a drug that's now approved for cervical cancer. And you can see what their different payloads are, but they're all, suffice to say that they're all different, they're all cytotoxic to cells. So I look forward to seeing many more studies and what the activity of these drugs will be in the future. So let's talk a little bit about immunotherapy. So there were 2, immunotherapy has been so exciting. It's been, Nobel Prize winning development over the past decade together with the PARP inhibitors. If I had to say what the 2 biggest things that have been developed, it's been both of those agents. And we obviously see great activity in melanoma, lung cancer, and some, we've seen in GYN, some really great activity in cervical and endometrial cancer. Unfortunately, we looked at this in the upfront treatment of ovarian cancer, thinking that it would be really helpful, right? Ovarian cancers, they express antigens. We know that then when there's a T-cell response, that patients do better. You would think that, gee, if we help that T-cell response be even better with a checkpoint inhibitor, that it would actually result in be even better. But unfortunately, both of these upfront trials were negative. So, we don't want to throw the baby out with the bathwater, but we need to take the opportunity to understand, if it's not going to help all comers, are there patients by which they would help? And secondly, how do we make patients more sensitive to these agents if they are resistant to it, much like what we see with PARP inhibitors, right? We know there are a group of ovarian cancer patients that are sensitive to PARP inhibitors, a group that aren't. So here's just a number of studies that are being looked at in the upfront treatment of ovarian cancer that are using the checkpoint inhibitors not alone, but in combination with PARP inhibitors, like we just talked about when we talked about PARP in combinations, and also sometimes in combination with an anti-angiogenic agent. And so I think these have the opportunity to tell us how effective these combination strategies may be in the upfront treatment of ovarian cancer. And these are looking at select checkpoint inhibitor trials in platinum-resistant ovarian cancer. There's a number being done by the NRG and GOG, and you can see they're all in platinum-resistant ovarian cancer, and they're all have a number of different arms that are looking at various different combinations like we talked about before. And then what about combination immuno-oncology strategies? Well, the checkpoint inhibitors have been really good. CTLA is another process by which the immune system is activated. This was a phase 3 trial randomized phase 2 trial that actually looked at nivolumab and ipilimumab. These were mostly platinum-resistant ovarian cancer patients. And we saw that when we used the combination agents, we actually had a better overall response rate and a better clinical benefit response. And so obviously the combination was a little bit more toxic, but it's promising, and I think that we need to do additional trials of various different immuno-oncology combinations. And this is a very interesting agent that is an immuno-oncology approach that utilizes an adenovirus that is given intravenously and has genes in it that actually have express proteins that have anti-angiogenic and immune stimulating properties. And so this is, I think, has just finished an accrual, and The preliminary analysis has demonstrated that we've had some higher CA-125 responses when we used a combination of this this VB 111 and together with dose-dense Taxol than when we use just dose-dense Taxol alone. So I'm gonna leave with some good news. This is just some recent SEER data. This shows, the actual incidence of ovarian cancer is going down. I think mainly due to the increased use of hormonal contraceptives, as well as some of the effort that Dr. Drapkin talked about with opportunistic salpingectomy. And you can see the mortality from ovarian cancer is going down. And unfortunately, the mortality from uterine cancer is going up, and we'll probably surpass that from ovarian cancer. But I think the most important thing here is that you see the prevalence of ovarian cancer is up. That means that there are more patients that are living with ovarian cancer longer, and that we're able to manage their disease so that they can live fruitful and meaningful lives for a longer period of time. We still have a lot of work to go, but I think this has been, it's been exciting to me to be on this 30-year journey looking at the advancements of what we understand about ovarian cancer and how we manage it. And so I think the take-home points are, from when I think back about how I thought about ovarian cancer when I was a fellow to what I think about now. We certainly know more about who's at risk for ovarian cancer, particularly understanding the BRCA genes and other genes that put increased risk. We know more about this biology of the whole spectrum of ovarian cancers, and that's leading us to develop novel therapeutics. We do better surgical procedures than we've ever done, and we have all these different novel and effective therapies. I've talked about the various different ones here listed for mainly high-grade serous carcinoma, but that, and Dr. Gershenson did a great job talking about those for the rare tumors. But it's been just an explosion of clinical trials over the past 5 years. And I think the next 10 years are going to be even more exciting as we get more insight into the disease process, more insight into novel therapies, and actually be able to get these therapies to our patients, and even those patients who, we know don't have as good access to clinical trials and to novel therapies as they should. We need to work on the disparity efforts, and we have better supportive care. So I think better days are ahead of us. And I really thank everybody for their attention. I'm happy to answer some questions.